I'd like to welcome everybody to the ASPI webinar today. I would say good morning, good afternoon, but not quite sure where everyone's located. First off, the general disclaimer, you might have seen it in the waiting room, but essentially all the information that you hear today, the opinions that are expressed are not intended as recommendations or medical treatment advice. We strongly suggest that you consult your doctor about any specific situations or any additional information that you might need. I would ask, and with that, I'd like to introduce to you Mark Lichty, our chair of ASPI.
Thank you, Joe. And I'd like to thank Dr. Bratt. Our presenters donate their time, and we much appreciate that, Dr. Bratt. Howard, thank you for hatching this idea. I'm really looking forward to this program, and I thank the project team too. And I'm particularly excited about this particular webinar because over 50 years ago, I lived in Sweden. And so I have a special place in my heart for Sweden. One of the missions of ASPI is to do a kind of a global scan and see if there are any practices that we might learn from. And in this case, we looked at Sweden, and we noticed that over 90% of the prostate cancer patients were going on active surveillance. And we in the United States have just over 50%. Now there's certain learning centers that are better than that, but as a whole in the US, we're down just over 50%. And so those statistics piqued our curiosity. And so this webinar came out of that. And in the US, 25 to 30% of the men are unnecessarily leaving active surveillance due to anxiety. And we want to see if we can help men to get treatment only if necessary and overcome that anxiety. All of us on the board have been on active surveillance. And the common thread amongst us is an initial sense of anxiety when first diagnosed or when confronting critical tests. In fact, my father died of prostate cancer, and I was wondering too, when I was diagnosed, if I would die of prostate cancer, because 30,000 men a year at that time died of prostate cancer. Now, it's kind of interesting because now my concern is no longer at all about prostate cancer. It's about where the next bathroom is. So we realize that anxiety serves no purpose. And part of our mission is to help you to progress beyond that anxiety and replace it with vigilance. I call it peaceful vigilance. And remember, you're not alone. Together, we can ease the anxiety in your journey. The prostate cancer arena is much different from how it was 16 years ago when I was diagnosed. Now we have all kinds of alternatives for detecting and monitoring and treating cancer. And our board membership is a unique blend of vigilant patients. Two of us, Joe, who you just heard from, and Throne, who's on this call too, have progressed gracefully to treatment. They have done this with vigilance research. And today, the end game or transition to treatment is clear with different safe alternatives than it was in the past. And by the way, in my case, I've progressed the other way. And my recent micro ultrasound revealed no clinical evidence of cancer, which is reason for rejoice. So we've got both ends of the spectrum here. And next month on our call, it's going to be a really interesting panel. We'll have Throne and Joe and some Gleason 7s and I might even talk about my own journey. I haven't quite decided whether I'll be on that call, but I might be on that panel. So I wanted to mention too that the European Prostate Cancer Organization, UOMO, has initiated a quality of life survey, and we're going to be sending that to you. And we hope you'll think about filling that out. And I again wanted to introduce you to Howard Walensky. He's one of our founders, and I have a profound respect for Howard, because he's not just a researcher, but he just takes on issues that need to be taken on. So it's a privilege to have him working with us, and he'll introduce Dr. Bratt, because he was the one that made that connection. And so Howard, why don't you go on with your introduction of Dr. Bratt?
Sure. Thanks for the kind words. Active surveillance has been a strategy for a quarter of a century to manage prostate cancer in men with lower risk disease. But as of today, only about 55% of such men opt to follow this path of close monitoring with biopsies and MRIs and micro-ultrasounds, et cetera. Of course, that means 45% choose radical surgery or radiation, with the risks of serious side effects such as incontinence and impotence. This is still a far cry from 11 years ago when I was diagnosed, and only 6% of American men adopted for active surveillance, and we had a fight to get it. Things have played out differently in Sweden, where more than 90% of these candidates opt for active surveillance. Doctors and patients in the United States and elsewhere in the world can learn a lot from the Swedish success story. Is it because Sweden has a socialized health system, as one leading urologist here in Chicago suggested to me? Or are Swedish urologists more persuasive and Swedish patients smarter? We're here to learn about Sweden's secret sauce for active surveillance and bring those lessons home. And we have the perfect teacher, Dr. Ola Bratt. Ola is the chairman of Swedish National Prostate Cancer Guidelines Group and also chairs the Committee for National Screening Program for Prostate Cancer. He is a principal investigator for randomized multi-center trial for men on active surveillance. As I said, we're going to hear it from the wise man on the mountain. Let me note that you should put your questions into the chat box. We'll do the best we can to get answers in the question and answer afterwards. And again, we cannot provide personal medical advice. So Ola, the floor is yours.
Thank you, Howard and Mark, for your kind introduction, and to ASPI for inviting me to give this talk. I was very pleased when you contacted me. I think it was about maybe half a year ago, Howard?
Yes.
Maybe more than that, that there is actually a specific patients organization for men on active surveillance for localized prostate cancer. I mean, you guys, I guess, most of you, if not all, are on active surveillance right now. And I know no other cancer or situation when it comes to prostate cancer that actually involves having a cancer without treating it for years and years. And as we heard from Mark, for some, and it's decades. So it's a unique situation. And you are absolutely helped by having this patients organization. I mean, if you have surgery, you get cured, you probably don't want to think so much about your cancer. Or if you're unlucky to have metastatic prostate cancer, well, there's no need for going into the patient organization for decades, unfortunately. So I was, again, very pleased to hear that there is such an organization. The title of the talk, The Sweet Smell of Success in Sweden, is Howard's idea. And this means that I'm not going to talk so much about which men should start on active surveillance, what kind of monitoring should be done, when is it time to get treated, and what kind of treatment should you then get. So I'll instead focus on what I think differs between Sweden and North America, and also start with giving you some statistics. I think actually the statistics is part of why we do have this sweet success in Sweden. So, okay, here we go. So as you heard, I'm chairman of the Swedish National Prostate Cancer Guidelines Group, and therefore I'm not allowed to have any honoraria from companies involved in prostate cancer care. So I have no conflicts of interest, more than I love my work and I work with prostate cancer patients. So let's start with Sweden. I know there are at least 3 guys among you 88 that are from Sweden, but the others are not. And to avoid being mixed up with Switzerland or Slovenia or any other small European country, you see Sweden is in the north here. I don't know if you see my arrow. We've got 10 million people. The capital is Stockholm, a very beautiful city indeed, sometimes called the Venice of the North because there's so much water and islands. It's actually built on an archipelago. I'm living and working in the second largest city, which is Gothenburg, or in Sweden, it's Swedish, Göteborg. It's actually the only city in Sweden that has both an English and a Swedish name. And the reason for that is that in the, well, many hundred years ago, it was the most important port for exchange with Great Britain. Gothenburg has about 700,000 people, inhabitants, 700,000 people. Sweden is a monarchy, but the king, or if we turn to have a queen in the future, has a ceremonial role only since about 100 years. So we have a parliament, we have a prime minister, and so on. And we haven't been to war since 1844, and I think that has affected our national character, both in positive and negative ways. I don't think that has much to do with the success of active surveillance, but it's worth noticing. We have a tax-financed public healthcare system. So you pay with the taxes, you also pay when you go to the doctor. It's about $20 or $30 to see a specialist. About 10% of the adult population also has private insurance. We have an excellent healthcare. If you have a stab wound in your tummy, we'll fix that with expertise. We do transplants, we do heart surgery, brain surgery on an international high level. But the waiting times in the Swedish healthcare system is among the worst in Europe, actually. So that's the reason for a growing proportion of the population having private insurance. Not to get good healthcare, but to get it in reasonable time. We do have excellent registers, not only for prostate cancer, other cancers, lots of registers, and they are all based on personal identification number, so we can easily link them, which makes Sweden a paradise for epidemiologists doing register-based research of various kinds, including medical research and prostate cancer research. We have a national prostate cancer register, the NPCR, that includes data for all 240,000 men who've been diagnosed with prostate cancer in Sweden since 1998. And we are presently launching a system for prospective registration of data for men on active surveillance, the PSA levels, MRI scan, biopsy data, who gets treated and who doesn't. And the NPCR provides publicly available statistics about prostate cancer, loads of statistics, and you can enter the website. It's available in English. It's open npcr.se. So go in there and see what you find. And I show you lots of slides with statistics that I've chosen from the NPCR website. We have national clinical prostate cancer guidelines since 8 years, and I've been the chairman since then, with the exception for a couple of years when I was working in the UK. And they are revised annually, and I think that urologists, oncologists that manage men with prostate cancer, you frequently go to the guidelines and see what's the recommendation for a man that I have in front of me right now. So this is the website. I took a screenshot, and you can see there were 8,900 new cases of prostate cancer diagnosed in Sweden 2020, and that means more than 1,000 fewer cases than the year before, and the reason for that is, of course, the pandemic with the coronavirus. Many men refrained from PSA testing, and many who had a raised PSA didn't get a biopsy because they wanted to keep the social distance. So as you can see on top, there are different sites to go to, and I go to treatment. And on treatment, there are numerous options. And of course, I clicked on active surveillance, and what do we see? So we see in the middle here, you can see that I can choose what healthcare region I'm interested in. I can actually go to the hospital level if I want that. I can choose the year of diagnosis that I want the statistics from, and I can include all years between 2010 and 2020 and produce graphs, or I can just choose 1 year, which I did now, so 2020. I can choose the age of the patients that I want to have the statistics for, and I can choose the risk group. And as you can see, I ticked for very low risk, and other low risk with missing classification between very low and low risk. And then you can see that in 2020, we had Sweden in the middle there, 1,578 men were diagnosed with very low or low risk prostate cancer, which then means that it was about 20% of all men who were diagnosed that year had a low or very low risk prostate cancer. And out of these, so I have to move that to see, it was 85%. So Howard and Mark weren't quite correct. So 85% of all men with any kind of low risk prostate cancer started on active surveillance. So let's proceed. And here we see, what if I do, that's better. Okay. So the bars, the zoom bars are obscuring my view. So I can't see what I'm looking at myself. So let's move that. Yes. So this is to show the variation between different regions. Still all kinds of low risk prostate cancer, and you can see it's between 100% in parts of Sweden and very close to 100%. National average, 85%, whereas some regions have lower proportions. The lowest here, as you can see, it's very low numbers, so a few patients more or less do affect the percentage quite a lot. So we can't really blame Västmanland there at the bottom for only starting active surveillance for 13 of the 18 patients in that county last year. So here you see the same group of men below the age of 75 years, and this is the proportion of men starting on active surveillance the past 10 years. In Sweden, active surveillance became popular around 2004, 5, 6, so that's when it started, but we don't have the detailed statistics online until from 2010 and onwards. And as you can see, there was quite a sharp rise from year to year, and now it's leveling out about 80 to 90% in the different healthcare regions. We've got 6 regions that are presented in the graph, and 1 is the national average, ending on 85%, as you know. This is the very low risk category, and here Howard and Mark were correct. We have a national average of more than 90%, and 1 healthcare region actually hits the ceiling with 100% of men starting on active surveillance last year, men with very low risk prostate cancer. I'll come back to the Swedish definition, which isn't exactly the same as the Canadian or the US definition, but pretty similar. Here again, very low risk, age up to 75 years, and this is to show the geographical variation. Some counties hit the ceiling with 100%, national average 94%, and again, very low numbers down here. So Stockholm, interestingly, is of the bigger counties, is definitely the one with the lowest proportion of men starting on active surveillance for very low risk prostate cancer. And of course, we can only speculate the reason for that, but I think it's fair to say that it is affected by that Stockholm has the highest proportion of private urologists, and there is also a private hospital with Da Vinci surgical robots. So I think this gives a hint of what I'm coming back to, the difference between Sweden and the US. There is usually no financial incentive for the urologist to operate, with the acceptance of some places in Stockholm. So there's probably a link there. Okay, so now we move on to intermediate risk. Certainly many men with a small intermediate risk prostate cancer will not have symptoms from their cancer before they die from something else. And the risk of dying, 70-year-old man with a small intermediate risk prostate cancer has a very low risk of dying from prostate cancer. So, but I was actually quite surprised when I saw these statistics when I prepared the presentation last week. I thought I would find an increasing trend, but I didn't. As you can see, it's pretty stable. The national average, about 20% of men below the age of 75. Surprises me. I thought we would be having more and more active surveillance in the intermediate risk group. And this is, again, a slide showing the geographical variation. Västernorrland, 40% of men with intermediate risk prostate cancer started on active surveillance. That's a lot. Västra Götaland, the third from the top, is where Gothenburg is. One of the biggest healthcare regions, as you can see, almost 1,000 men with intermediate risk prostate cancer diagnosed last year, and 28% started on active surveillance. Whereas in Stockholm, it was exactly half of that, 14%. So definitely a significant geographical variation. Then, of course, one wonders, has the high rate of active surveillance in Sweden compromised survival? Well, the statistics can't give the answer to that, because there would of course be a lag time of at least a decade. But we do have a very rapidly decreasing age-standardized prostate cancer mortality in Sweden in men aged younger than 80 years. So there is definitely no sign that we've done anything wrong over the past 25 years. On the contrary. So how did we achieve the high active surveillance enrollment in Sweden? I touched on the tax-funded healthcare system as opposed to the system in North America. So that means, with the exception for some urologists in Stockholm and in Gothenburg, actually, there is no financial benefit for urologists to operate on men with prostate cancer. It's a fact that many urologists in the US have been very wealthy indeed because of the boom of PSA testing in the 1990s, which in turn produced a boom of radical prostatectomies. And of course, I'm not saying that your urologist thinks more about money than his patient's benefit, but of course it does affect the national statistics. We also have a medical legal system that is, I think, also a difference that may be even more important, to be honest. If I have a man in front of me and I would miss the window of curability, I would delay radical treatment a year too long, he would develop metastatic disease, quick recurrence after surgery. I guess that that could potentially lead to lawsuits in the US if you have not followed strictly the guidelines for active surveillance, but it wouldn't happen in Sweden. So probably nothing at all would happen. And if anything would happen, if the patient would go to the authorities, there would be at most a kind of warning for the urologist, and he wouldn't be sued for $1 million, which I think could happen in the US. That's, of course, some of importance too. I also think, as I mentioned in the start, that our registers and clinical studies that I will come back to, they clearly show the extent of overdiagnosis and overtreatment, and showing this to the urologist, to the patients, I think that's the important part of teaching, well, healthcare professionals and patients alike, that men with low-risk prostate cancer do not need treatment, most of them, that is. We also have had a very strong recommendation for active surveillance since the first version of the national guidelines in 2013. And that coincided with the introduction of the very low risk category. And I think that was very important. And I'll come back to why I say that. So this is a chart showing the past 50 years of the age standardized incidence of prostate cancer in Sweden. So we do have about 10,000 cases, but if we age standardize, it's now about 200, 250 diagnoses per 1,000 men, that is, so it's not men and women, but it doesn't matter much. As you can see, at around the turn of the century, there was a sharp rise going up, and that it's been stable around 200, 250. And that was the same that was observed in the US and most other Western countries. The US was about 5 to 10 years ahead of us. So your peak came, I think, about 1995, or something like that, whereas our peak came in 2004. But of course, there was a rising incidence also before the introduction of PSA, because as you understand, that was what happened in the 1990s and late 1980s in the US. PSA was starting to be used on men without a clinical signs of prostate cancer. And that is, of course, the reason for the sharp rise there. So if you focus on this part and draw a line from the increasing incidence before we started to use PSA for early prostate cancer detection, you could assume that the incidence would have continued to rise in a similar fashion, probably would have leveled off, but let's say it would have risen as much as that. So that would mean that what is over the black line there is overdiagnosis. And you can calculate that that means that 60,000 men with indolent prostate cancer who would never have been diagnosed if that man hadn't been PSA tested. So he wouldn't have had any symptoms for prostate cancer until he died from something else. 60,000 men over about 20 years of time. And since Sweden has 10 million people and the US has 300 million, that means that if you translate the figure of 60,000 to the US population, that would mean almost 2 million men in the US, which I think has been reported that it is actually about estimated to be 2 million men in the US that have been diagnosed with prostate cancer, overdiagnosed because of PSA testing and systematic prostate biopsies. Men who would never have had any problems with prostate cancer before they would have died from something else. And the reason for that could happen is that prostate cancer is like an iceberg. I often return to this metaphor. What you see above the water surface is the clinical prostate cancer that gives rise to problems with urinating, pelvic pain, metastases, and death. Whereas under the water is the prevalent prostate cancer that does not progress into clinical disease. If we do autopsies in men in middle age, upper middle age who die from something else, motor car accidents, heart attacks, falling down from Mount Everest or whatever, about a third of those men do have prostate cancer without noticing it. And if you go to older men, about, well, say the age of 80, it's about half of the men. And clearly, if we look thoroughly with biopsies and search for small prostate cancer, we inevitably pick up those indolent cancers. And when we've found them, it's very difficult to be absolutely certain that that specific cancer won't progress. And of course, we are more likely to overtreat than undertreat an individual patient. We don't want to sit there saying to Mr. Anderson that I'm sorry, I should have operated you 2 years ago. Now it's too late. But with time, we've learned more and more about prostate cancer, low-grade prostate cancer, and the indolent nature. So I'll come back to that. But that's the explanation for the overdiagnosis of indolent cancer. There is a lot of prostate cancer under the surface of the water. We now know that what is called Gleason pattern 3 prostate cancer, in other words, low-grade prostate cancer, does not metastasize. We didn't know that when we started using active surveillance around 2005, 2010. These studies emerged in the 2010s. So I'd say it's been the past 5 to 10 years that we confidently can say to a man with a Gleason pattern 3 prostate cancer that your cancer, the cancer that we've found in your prostate, will not metastasize, it will not spread to other organs, it will not kill you. So active surveillance is first to make sure that that man doesn't also have a more aggressive cancer. And of course, monitoring him over time to see that we didn't miss a very small high-grade cancer that grows over time, or that indeed his Gleason pattern 3 cancer over the years changed the biological features and actually becomes Gleason pattern 4 or even 5 cancer. So this is another study, or it is a study, I haven't shown any studies before, that has taught us that overdiagnosis is an issue and a problem with PSA testing asymptomatic men. So there are many prostate cancer screenings trials all over the world, and one in the US, there are many in Europe. But the parts of the European screening study that have been the two high quality screening parts of it, it's been Gothenburg and the Netherlands. It's only in the Gothenburg screening trial and the Rotterdam part of the European trial that men have repeatedly had PSA tests over a long time and complied well with biopsy recommendations. So I'm not showing you the graph that shows the decreased mortality from screening in the screening group. I'm showing you the graph that shows the proportion of men diagnosed with prostate cancer in the two groups. So here, the control group that was not invited to screening over the years, of course, had a rising proportion of men being diagnosed with prostate cancer. So after 15 years, it was 10% of those men who had been diagnosed with prostate cancer. Whereas those men who'd been invited to a PSA test every second year and a systematic biopsy, if the PSA was more than 3, they had a 15% chance of being diagnosed with prostate cancer after 15 years. And that difference between the two curves represents indolent prostate cancer that wouldn't have been diagnosed without the PSA test. And in fact, the true difference is higher, because in the screening group, only about 75% of the men did have a PSA test. So 1/4 did not have a PSA test. And the opposite, in the control group, about 1 out of 4 men did have a PSA test without symptoms. So if you would compare men who had a PSA test with those who didn't have a PSA test, the difference would be bigger. And as the curves do not approach each other after several years, we can safely conclude that the difference is overdiagnosis. Let's go to the PIVOT trial. It's an American trial reported a couple of times in the New England Journal of Medicine, and the last report was in European Urology. So that was a trial in which men with localized prostate cancer, low risk, intermediate risk, and high risk, were randomly allocated between having radical prostatectomy or watchful waiting, expectant management without any plan to go and proceed to curative treatment if they had progression of their cancer. And if you choose the group that had a low-risk disease, there was absolutely no difference, statistically significant difference, and no difference at all between the two groups. Those men who had a radical prostatectomy had the same risk of metastatic disease after 10 and 15 years as the men who started on expectant management. And that was a very low proportion indeed. As you can see, it was about 1 in 200 men. So 0.5 to 1% of the men did have metastasis after 15 years. So 99 or 99.5 men didn't have that. And if you go and see the death from any cause, of course, the curve started rising much earlier, but there was again no difference between radical prostatectomy and observation. As you can see, there was a slight advantage of having observation over radical prostatectomy. But of course, men do die, and these men, about half of the men had died after 15 years, but none of them had died from prostate cancer. So no difference no benefit shown, at least no medical biological benefit from prostate cancer, from radical prostatectomy was seen in this trial. But of course, there were other effects of having radical prostatectomy. The left graph shows the difference in men reporting sexual dysfunction. About 30% of the men in the control group, those who had no treatment, reported sexual dysfunction. But of course, that rose significantly among the men who had a radical prostatectomy, up to 70% after 6 months. And then over time, of course, men's sexual function do deteriorate over time. So they were about 65, 70 years when they started. And after 10 years, also in the observation group, more men did have sexual function. But there was a significant, very significant difference the first 5 years between the groups. On the right side, you see men with urinary incontinence, very low rates indeed among the men who had observation only, whereas about 30% of the men who had a radical prostatectomy reported using more than 1 pad a day after 6 months, and then going down to about 1 in 5 men, but it's still a substantial number. So it's fair to say that based on the PIVOT trial, we can conclude that for men with low-risk prostate cancer, there is no benefit in terms of reducing the risk of metastasis or death from having a radical prostatectomy, whereas it's documented that they have a higher risk of problems with their sex life and with urinary incontinence. So what do you think if a pharmaceutical company made a similar study and applied to the FDA to register their new drug? So they would say typically, okay, we've got a new drug that we would like to use for men with prostate cancer. And we've got a trial here showing that after 15 years, there's no benefit. There is side effects, certainly. Some men have urinary incontinence and some, quite a few, most men actually, have sexual problems. And the cost of this treatment is about, I don't know what it costs in the US, but let's say it's about $15,000. Do you think the FDA would approve of that treatment? Well, of course not. So why do the guidelines approve for having radical prostatectomy if for men with low-risk prostate cancer? That is an enigma. And as some of you know, the American guidelines, NCCN, the National Comprehensive Cancer Center Network or something, they previously recommended against radical treatment for men with low-risk prostate cancer, but since about a month, they put active surveillance on level with radiotherapy and surgery. And many people, urologists, oncologists, patients, others, have protested because there was no argument really for why they did that. I have no idea. Anyway, let's move on. Let's go to the Swedish prostate cancer guidelines. As I mentioned, I think that they definitely contributed to the success, not least since we, in 2013, when the guidelines were issued the first time, defined the group of very low-risk prostate cancer. So low risk is the same in Sweden as it is in the rest of Europe and in the North America. It's Gleason score 6 cancer, non-palpable, that is tumor stage T1C, and a PSA below 10. And the very low category is similar to the NCCN guidelines. It's a PSA density of less than 0.15. We do allow up to 4 positive biopsy cores out of 10 to 12 because we did a study showing that. And of course, where the study is done, it has the highest impact. It hasn't affected the US. And a total biopsy core cancer length that was no more than 8 millimeters. So say if you had 3 biopsies with 2 millimeters each, that's fine. That's still very low risk prostate cancer. Whereas if you had 3 biopsies with 3 millimeters each, that would be 9 millimeters, and the cancer would have been classified as low risk, but not very low risk. For low risk prostate cancer, the guidelines say that active surveillance is the first choice. Surgery or radiotherapy may be considered. There may be specific reasons, such as a rising PSA, very high volume, Gleason score 6 cancer, high PSA density, suspicious findings on the MRI. Maybe the man his brother died from prostate cancer and he definitely wanted to have surgery. Well, there are many reasons for men to choose radical treatment, despite the fact that they have a low risk cancer. But definitely the guidelines says that on average, the average man, active surveillance is the first choice. The next recommendation, I think, is unique to Sweden, and that's part of the success for the very low risk group. Active surveillance is recommended, full stop. We shouldn't even discuss with these men with a recently diagnosed very low risk prostate cancer, surgery or radiotherapy. We should just say, okay, we've got good news for you. You have no cancer that needs treatment. We must, on the other hand, monitor the cancer over time and see that we haven't missed anything or that this cancer doesn't grow more than we think. But surgery and radiotherapy is not needed. And that is definitely different from the rest of the world, I think. And I'm showing you again this graph, up to 100% in one of the healthcare regions. I think this way of viewing very low risk prostate cancer is of importance, and I'll come back to that here. The importance of using the right words. So this is not the right way to inform a man that's been diagnosed with low risk prostate cancer, dragging him into the theater more or less, saying that he's got a cancer. But things have changed. When I started recommending, or I didn't recommend actually, I started presenting active surveillance as an option for men with low risk prostate cancer about 15 years ago. When they came to me to have the results from the biopsy, I said, I'm sorry, you've got prostate cancer. And of course, as many men with prostate cancer or other cancer forms have witnessed, if you hear those words, there's a black curtain going down and you don't get much of the rest of the information. You are in shock. So, but that was what I said. Bad news, you've got prostate cancer. And then I explained that this kind of prostate cancer, it's very small, it's unlikely to grow. So you may not need surgery. We can cure you with radiotherapy or surgery, but you may not need it. So we may see what happens if you don't have radical treatment. I think that that way of giving the cancer diagnosis to a man is not exactly good advertising for active surveillance. Because if you hear the word cancer, the first reaction is and should be, get rid of it, because that's what's the usual treatment for any cancer. But with time, I've grown more experienced, and above all, the science and research has told me that low-risk prostate cancer isn't dangerous. So this is out, and nowadays, I say when a man has very low-risk prostate cancer, he comes into the room, often with his partner, and I look happy, and I said, good news, Mr. Anderson. You've got no prostate cancer that needs treatment. and then his shoulders falls down. He's relieved, he's looking happy towards his partner. And I let that sink in. No cancer that needs treatment. And then 30 seconds later, I say, but there are the type of cancer cells in your prostate. That's not dangerous, they won't spread, but we do have to monitor you. So the good news is that we'll have the opportunity to get to know each other quite well over the coming years. But there's no reason to operate or give radiotherapy for that kind of cancer you've got. We know that that cancer found in the biopsies is not dangerous. And I think that's a significant change from the way I informed men 10 and 15 years ago. And I'm sure that if the doctor is confident with active surveillance, he's happy not to bring bad news, then the patient is happy too. And I think that is a key to successful active surveillance. A happy patient that is just pleased that he doesn't have a cancer that needs treatment. That historically at least, many doctors haven't succeeded to give that impression to their patients is made clear by this German study published 5 years ago. So of course, things probably changed in Germany too. But they interviewed men with a questionnaire. I think it was about 200 men who had a recently diagnosed Gleason score 6 cancer or 3 + 4 = 7. So a very low to nil risk of dying from prostate cancer over the next 10 years. And they asked them, what do you think your risk of dying from prostate cancer would be if we started you on active surveillance? And the patients on average responded, my risk of dying would then be, dying from prostate cancer would then be 50%. And repeated the question with, what do you think your risk would be if you had surgery? Then still they thought that their risk was almost 20% of dying from prostate cancer. And in fact, the true numbers would be about 1/10 of those numbers. So of course, if you think your risk of dying from prostate cancer is 1 in 2 if you start on active surveillance, no way. And still, after surgery, they think or thought, or some years ago, that their risk of dying from prostate cancer was almost 1 in 5, which tells a lot of the anxiety for men having prostate cancer even after surgery. So let's go to the UK. I was working there for a bit more than 3 years, and my colleagues in Cambridge, they've produced another online tool that's called Predict Prostate. If you Google it, you can enter, it's absolutely free. So start Predict, we press that button and see what we find. So then we come into this kind of sheet where you can enter your data, your age of diagnosis, your PSA, clinical stage, if you've been admitted to hospital the past 2 years, not for prostate cancer, for any reason, if you have a mutation of the breast and prostate cancer gene, your ethnic origin, and then on the right side you see you tick the boxes for the type of cancer you've got. So I chose a 65-year-old man with a PSA of 6, T1C cancer, 3 + 3, 12 biopsy course taken systematically, 4 biopsies with cancer, no of the aggressive forms of Gleason pattern 4 cancer, and of course no spread from that cancer. And then you can get charts, icon, curves, table, or the matters explained in text as you choose, and I chose icons. And that says with conservative treatment, if you have 100 men with the type of cancer that you have, that are as old as you are and have about the same comorbidity, you can see that 68 would still be alive without any radical treatment for their prostate cancer. 32 would have died. 6 would have died from prostate cancer without any curative treatment. Whereas if you take for radical treatment, still after 15 years, you see that there's not much difference. Most men would, of course, not die from prostate cancer, but the difference would only be 3 men. So as you can see, 3 prostate cancer related deaths. So 97 of the 100 men would have no benefit from the operation in terms of prolonged survival. There could be other benefits. And you could also find out the risk of erectile dysfunction with conservative treatment, nerve-sparing prostatectomy, non-nerve-sparing surgery, and radiotherapy. You can see the increased risk with any kind of radical treatment. Same for incontinence, very low risk of incontinence if you have no treatment, of course, whereas with radical prostatectomy, about 1 in 5 will have some urinary incontinence. Bowel issues, not much of a problem with surgery, but some of the men who have radiotherapy get bowel problems. The last 5 or 10 minutes I spend on MRI, magnetic resonance imaging. So that has dramatically changed the way we feel about active surveillance. So clearly MRI reduces the risk of missing a high-grade cancer. As you know, and I said maybe 5 minutes ago, we were concerned that although the biopsies had shown only low-grade cancer, we might have missed a high-grade cancer somewhere in the prostate. And at the start of the active surveillance eras, there was quite a few studies that reported of the results of operating on men who actually fulfilled all the criteria for active surveillance. And they reported that about 1/3 of those men did have a high-grade cancer that was missed by the biopsies. Using MRI substantially reduces that risk. And since 2015, a magnetic resonance imaging scan is mandatory before starting on active surveillance. And clearly, using MRI before active surveillance and during active surveillance reduces the urologist's anxiety and thereby definitely the patient's anxiety for missing a high-grade cancer. MRI for follow-up, the role is not quite as clear as it is for selecting men for active surveillance. There are not as many studies, and the optimal way to use MRI for follow-up for men on active surveillance is not quite clear. But certainly, we now, in a way that we just couldn't until we started using MRI, we can follow individual lesions in the prostate. So if we take a biopsy from a 6 millimeter lesion and find that's Gleason score 6 cancer, with a repeat scan in a couple of years, we can see usually that it hasn't grown. Or if it has grown, we can rebiopsy, see if it's a more aggressive cancer, or even if it's grown a lot, I would many times recommend the man having to have surgery or radiotherapy rather than a biopsy, particularly if also the PSA is risen, because that makes it very likely that it is a high-grade cancer in that lesion. But anyway, it's a new era. In the early days of active surveillance, we follow the PSA, we did repeat biopsies, but now with MRI, if there's no visible growth of a lesion on MRI and no rising PSA, it's a very, very low risk of cancer progression. The past few years, I don't recommend the men to have a biopsy if their PSA is stable and the MRI shows no progress. And that's a good thing. Biopsies are not a good thing to have. I have had an MRI, not of the prostate, but I had an other MRI, but I've never had a prostate biopsy, and I'm glad I haven't. But all of you guys have had it, and I'm sure many of you have had repeated biopsies and would be happy not to have any more, if not necessary. Also, a good thing with MRI is that it reduces the detection of low-risk prostate cancer in men with a raised PSA and a clinically benign prostate. And that's a more recent progress in the Swedish healthcare of men with prostate cancer, that we now use MRI before biopsy. And that means that about a third of men with a raised PSA has a normal MRI scan, and if the PSA isn't too high, there's no need to do biopsy at all. So we just send him back to his general practitioner and suggest he has repeated PSA tests over the next several years, but no need for a biopsy. And if we don't do biopsy, of course, we don't have the risk of overdiagnosing with an indolent prostate cancer. And actually, since we introduced this in 2020, the incidence of low-risk prostate cancer has decreased. There is, of course, the problem with the pandemic that in itself made the incidence of low-risk prostate cancer decrease, but I estimate that we diagnosed 500 fewer men with prostate cancer in Sweden last year because of the MRI first routine. And that's a very good thing. The best form of active surveillance is without even diagnosing the cancer. So this is an illustration of the use of MRI for men on active surveillance. This is a study, quite old now, published 8 years ago. So they had 64 men with very low risk prostate cancer. They took them to theaters, surgical theaters, in general anesthesia. They did transperineal template prostate biopsy, 1 biopsy core per cubic centimeter prostate, on average 58 biopsy cores. So we can be confident that they mapped the prostates very well indeed. And the numbers here is where they found cancer. And not surprisingly, it was the front part, the ventral, the anterior part of the prostate that harbored most cancer. And that is, of course, with using systematic biopsies, which we did before the MRI era. We didn't reach that part of the prostate. So anything in the red circles wouldn't be sampled by the routine systematic biopsy. And that was, of course, where most of the high-grade cancers were hiding. As I said, 1/3 of men who fulfilled the criteria for active surveillance, if you operated on them, they actually turned out to have high-grade cancer. And most of that high-grade cancer was hidden in the front part of the prostate. But with MRI, there's a good chance of detecting that cancer. And if we see it on the MRI, we can do targeted biopsies and find that Gleason score 7 or 8 cancer, or 9 even, before suggesting active surveillance. And that's a very big advantage with MRI-based diagnostics. This is a randomized trial that really speeded up the introduction of MRI before biopsy. It was published in the New England Journal of Medicine in 2018. Most of you may know that New England Journal is the most prestigious of all medical scientific journals. So men were randomly allocated to the control arm or to the precision paradigm, as they call it. So the control arm, they had standard systematic biopsy. And of the men in the trial, 26% had what we call a clinically significant cancer that we did want to detect, whereas 10 to 22% of them had a low-grade prostate cancer. That is actually better not detected. Whereas in the MRI group, they had an MRI and they had targeted biopsies only. They detected more cancer of the type we do want to detect, and less than half as many Gleason score 6 cancer. So a clear advantage of the routine to do an MRI and target the visible lesions only, except for men with a very high PSA, because MRI can miss prostate cancer. But most men with a normal MRI do not need any biopsy at all. So the conclusions. PSA testing followed by systematic prostate biopsies detects many indolent cancers that would be better undetected, better left alone, better have a man without knowing that he has cancer, better have a healthy man with than a prostate cancer patient. There is absolutely no evidence for any kind of benefit, medical benefit, of treating men with low-risk prostate cancer. Based on studies, that's average over many men, there are certainly individual men who should have surgical treatment or radiotherapy with low-risk prostate cancer, but there's no scientific evidence on a group level for a benefit. The Swedish healthcare system and the medical legal system in Sweden facilitate active surveillance for low-grade prostate cancer, not least the introduction of the very low-risk category. We have excellent national registers with open access, and that probably adds to the success of active surveillance. We can detect regional variations, and if one region or hospital has a lower proportion of active surveillance, we can discuss with the urologist there, why are you doing this? So good registers with up-to-date open access information probably helps us to have a high proportion of men on active surveillance. Clearly, MRI reduces detection of indolent prostate cancer. It's a very strong, important leap forward for mankind, I would say. And MRI reduces the risk of missing high-grade prostate cancer, as important as reducing overdetection. And clearly, when the urologist is convinced that active surveillance is safe, that patient is less anxious. And a happy urologist means a happy patient, most of the time. So this is the night view or the evening view from Gothenburg. It's actually it's 7:15. Dark outside, it's Saturday evening, but the floor is open for questions, and I guess Mark or Howard will